Please have a seat. We are going to begin again the second part of the first session. Lesson learned from outbreaks of the past. So this second part of lesson learned is has a specific question. You have the program in your folder. I'm going to continue to talk until the people sit. So the specific question is, to what extent have key lessons learned from past outbreaks or health emergency been applied and improved the control of recent epidemics? So we have for the second part three speakers. David Heyman, the head and chair of Public Health England and Chatham House, and he's going to talk about SARS and the 2005 revision of the IHR. Harvey Feinberg, the president of the Moore Foundation, and he's going to talk about how well did the IHR work during the H1N1 pandemic. He was the chair of the review committee of H1N1 response, IHR, during H1N1 response. And the third speaker is going to be John Liu, the president of Médecins Sans Frontières, and she's going to talk about Ebola as a humanitarian and healthcare crisis. So I invite David Heyman, that is not here. Oh, there is. Hi, Heyman. To begin, have 20 minutes.
Thank you very much, Minna. What I've been asked to talk about is the response to SARS and the 2005 revision of the international health regulations. And what I would start with, well, I didn't start very well. What I would start with is just a refresher course on the international health regulations, which were developed in a different time, in a less globalized world. And they were developed to stop infectious diseases at borders, to ensure the maximum security against the spread of disease with a minimum interference in world traffic. There were the regulations, and there were two guidelines for the border areas, one for shipping and one for airports. Now, the regulations had three requirements: notification to WHO of 3 infectious diseases, cholera, plague, or yellow fever, and reports were only accepted from countries where the event was occurring. Health measures, they described the maximum measures that a country could require to protect at its border against cholera, plague, and yellow fever, and it required certain organization at ports, airports, and frontier posts to prevent vectors from proliferating. This is a form for the IHR from Singapore, just a shipping form, and I think it's important just to note that this is a form which is in the past century. These were regulations that were developed with the early 20th century in mind, not the late 20th century. Now, how they worked was very interesting. Countries reported to WHO, and then WHO published, I might add in very small print on the back of the weekly epidemiological record, the information about where an outbreak was occurring once the country reported it. When that was published, borders could take certain actions, such as requiring a yellow fever vaccination if there were a yellow fever outbreak in the country, such as Senegal. All conveyances coming from Senegal could be required to have their passengers vaccinated against yellow fever. A very passive system, one that required disease reporting by countries of 3 diseases, publication then in the weekly epidemiological record, application of predetermined measures such as requirement of a vaccination certificate, and a national containment activity. Very passive, as Margaret said earlier. And these regulations were very unpopular because they caused economic difficulties, and this shows you when Peru and Tanzania reported cholera and India reported plague, what happened to their economies. At the same time, the regulations were really quite outdated and didn't take into account many of the other emerging infectious diseases, which are considered to be very important in a globalized world. And so in 1996, the Director General at WHO set up a new program, the Emerging Infections Program, and in that program were included the international health regulations to be revised based on a resolution from the World Health Assembly in 1995. Now, the vision was developed before the regulations were actually revised, and that was a world on the alert and able to detect and collectively respond to international infectious disease threats within 24 hours, using the most up-to-date means of global communication and collaboration. This was developed with a group of experts in the Emerging Infections Program, advisors to that program, and it was understood that no matter what would happen with the regulations, they probably would not have the teeth necessary to require reporting and enforce it. And so it was felt at the same time in that vision that there needed to be a change in the norm so that infectious disease outbreak reporting is expected and respected. Two visions which were pulled through into the revision of the international health regulations. But they were operationalized in advance. They were operationalized within WHO, and that required 5 or 6 different policy interpretations. And the first of those was a decision to accept and act in confidence with countries on information about disease outbreaks from sources other than countries. Now remember, WHO was only taking information from countries. This was a major change. The legal department was very uncomfortable with this. This was, however, finally accepted with justification that this would be treated in confidence with countries, and that was the decision made. That decision permitted taking information from many different sources, including ProMed and the Global Public Health Intelligence Network of Canada, which was actually set up in support of the Emerging Infections Program at WHO, to search the web, providing information on possible outbreaks that were occurring. This is how the network looked on a scheme. Above in green, with the green arrows, are formal reporting sites to WHO, formal sites that reported to WHO. Underneath are informal groups that reported to WHO about infections. When this information was received in WHO, and it was received every day, there was a morning risk assessment with work through country and regional offices to determine whether the rumor or whether the report was valid, and if it was so, what was going on and how it should be addressed. This was a very powerful system, and just to show you, in 1999, GFIN, sitting up in Canada, reported to WHO a highly fatal outbreak of respiratory disease in Afghanistan. This report was picked up from an English-speaking site in Tajikistan, which was relaying information from a border post, a newspaper at a border post, translated into English and then provided to the world. WHO local team did a preliminary investigation. A collaborative team then went in, and the investigation was completed, diagnosis confirmed, and the outbreak stopped. It was actually influenza, seasonal influenza, in a population that had not had previous history with influenza, at least in the previous 30 years. But all of a sudden, legal at WHO became even more concerned, because on the left you can see reporting from countries through regional offices, and on the right you can see where the major part of the information was coming from, which was from GFIN, the Global Public Health Intelligence Network, scanning the web in Canada, ProMed, NGOs such as MSF, Red Cross, Red Crescents, and others. So this was a fact which had to be accepted, and legal did accept it. And when WHO received these reports through the Global Outbreak Alert and Response Network, it then requested electronically support from, at that time, the 120 members who were in the GORN network, providing technical support to WHO, through WHO, to countries. A resilience fund was set up at WHO with help from the Nuclear Threats Initiative in the US, and there was a fund, a rotating fund set up within WHO so that the GORN Secretariat, which at that time was about 5 or 6 people, could respond rapidly to a country situation and bring in the necessary people and then replenish that fund after it was over. This shows you between 1998 and 1999 the responses, some of the responses which occurred during, in this new mode of working, the Global Alert and Response Network. Now, this is a schematic of that Global Alert and Response Network, and what it shows you is various networks that are not WHO networks, but that are networks which were willing to report to WHO on events that were occurring. There was Canada GFIN, which circled the globe. There was the Global Influenza Surveillance Network, which circled the globe. And there were many regional surveillance networks as well. And on the 16th of November in 2002, it was ProMed and GFIN from these networks surrounding the globe that there was a report that came from China about an outbreak of respiratory illness. The government was recommending isolation of anyone with symptoms. And when WHO questioned the government, they replied that there was normal influenza B activity at that time and that this did not constitute an alert. But there was continued reporting out of China, and by the 11th of February from Guangdong, again, an outbreak of atypical pneumonia among health workers was reported in a text message to the WHO office in GFIN. The official government report back to WHO at that time was an atypical pneumonia outbreak, 305 cases, 5 deaths, influenza virus not isolated, finished. But then on the 19th of February, Margaret Chan and the group from Hong Kong reported to WHO a 33-year-old male and a 9-year-old son in Hong Kong reported with avian influenza, source linked to the Fujian province. This caused great global concern because the concern was that H5N1, which had been identified in 1997 for the first time in humans in Hong Kong, was beginning to manifest itself as a global pandemic. And so the Global Influenza Surveillance Network was activated, and throughout the world they were ready to receive specimens of suspect influenza. On the 26th of February in Hanoi, a 48-year-old businessman with high fever, atypical pneumonia, and respiratory failure came to the attention of the WHO country office that reported this to Geneva. This was not influenza. The network was active, did not isolate influenza. 4th and 5th of March from Hong Kong and from Hanoi, there were reports of medical staff who had an atypical pneumonia, not influenza. And there was need for another policy decision at that time. Global alert in a WHO press release as a means of assuring widest possible information uptake by governments. WHO at this time had no direct communication with any focal points in countries who were ready to take information, and the only way to get to all countries, in addition to some other possibilities, was to put out a global alert in the press. And this is the alert. Atypical pneumonia, South Asia, and describing the disease, requesting that any country with this report to WHO. On the 12th of March, that alert was made. 14th of March, Canada, Singapore reported that they had similar infections to WHO and that they fit the description in the 12 March alert. And on the 15th of March, Mike Ryan, who was the duty officer for Gorn on that day, received a call at about 3 in the morning from Singapore saying that a medical doctor who had treated patients in Singapore had gone to the U.S. for a medical conference, was on his way back, and was sick along with his wife. Would we help them get him help in Singapore, or in Frankfurt, where the plane landed? So on the 15th of March, which was a Saturday morning, Mike Ryan awakened at 3 in the morning, the rest of the team coming in with the Director General looking at what was going on. And this is what was known. An atypical pneumonia with rapid progression to respiratory failure. None of the patients had yet recovered, known to have recovered, those that were registered. Health workers appeared to be at greatest risk. The cause was unidentified. Antibiotics, antivirals not effective. And it was spreading internationally within Asia and Europe and North America. Now, this did not fit in to the international health regulations. And so there was a need to make another policy decision, which was that airports were to report sick patients if traveling from areas where outbreaks were occurring. Precautionary measures as a part of a global containment activity. And this is the press release that went out on the 15th of March, travelers giving a case definition of the disease. Now, this was done on the 15th of March, a Saturday morning, without consultation with member states, which was a very great risk for WHO, but it was done because it was an emergency and it was felt it needed to be done. Next policy decision was to proactively collect information in real time from countries where outbreaks were occurring and from other sources. And so 3 virtual networks were set up, managed by WHO, and at this point there had been 5 secondments from the United Kingdom to WHO Secretariat to work on the Gorn response. These networks set up virologists, a network of virologists, clinicians, and epidemiologists who were regularly exchanging information either through a secure website or by telephone or video conference. It was very effective. Very rapidly, by the 22nd of March, remember the 15th, these networks were set up the 17th. By the 22nd of March, already there was a complete genetic sequence, and it was known that this was a human coronavirus. And these are some of the other factors that were found. At the same time, the clinical group was using standardized investigation and patient management forms to develop trials and treatment algorithms that were put out on the web regularly, updated, so that best possible treatment could be offered. And the epidemiological group set up guidance on surveillance, and that guidance was taken by most countries, including, you can see here, CDC adapted these from the WHO website for their surveillance activities. And situation reports were received regularly at WHO through 21st century communication mechanisms on the internet. And epidemiology was rapidly understood as well. And it was also understood that SARS was traveling on airplanes, and this shows you CA-112, a flight that was going to China. And you can see on this a patient circled in red and all the different people who were infected, either on the airplane or most likely many of them in the waiting room, because this patient was very sick at the time he got on the plane. Now, SARS, the international spread, was identified by Margaret and her team in Hong Kong at that time by doing some interesting epidemiology, which we'll talk about in a few minutes. But what was important was Hong Kong was sharing this information globally. And it was soon known that a doctor from Guangdong province had come into Hotel M in Hong Kong, and in that hotel had spent one night, and during that one night, people returning to the countries listed had become sick, including the first patient to come to notice in Vietnam. This shows you the hotel floor. All these patients were infected on one hotel floor, and in the investigation afterwards, there were PCR fragments of the virus found in the carpet in front of the room in which the initial doctor from Guangdong province was staying, and other evidence that there was possibility of spread. This, like all major emerging infections that are respiratory or by body secretions, including Ebola, was at great risk for health workers. They not only got infected, they inadvertently took the infection to their family members and into the community and to other patients. Now, Margaret, back in Hong Kong, did a very interesting epidemiological exercise, again in the 21st century, making sure that they could take maximum benefit of everything they had. The police system, which was called MIDAS, which was set up to identify clusters of petty crime every day, was used for the SARS outbreak. And so a separate channel was used, and in the police department there were actually people from the health department sitting, registering information about patients so that every morning they could print out a cluster that they might have found of cases. And you can see here there was a couple clusters at restaurants in Hong Kong. The major cluster that was found, though, was a cluster at the Amoy Gardens apartments in Hong Kong, where it was known that SARS was continuing to spread internationally. And at this outbreak, which was very unusual, there were 321 cases and no evidence of face-to-face contact of people with patients with SARS. It turned out that this was probably a whole series of issues which ended up in providing an aerosol to people who were bathing at the time of the outbreak, just a Swiss cheese event, if you would. Several events lined up so that you could end up with an outbreak. This was thought to be due to the diarrheal disease of someone on the top floor who did have SARS, the pipes becoming blocked, poor valves into the bathing areas, and a whole series of events which caused aerosolization. But it was not known at that time what caused this. And so it was thought that maybe there was some vector or some reservoir in nature which was transmitting the disease as well. And so there was need for another policy decision, and that was to recommend that people avoid unnecessary travel to sites with possible environmental transmission. This manifested itself in a very unpopular way, where WHO actually recommended that passengers not travel to countries, or that they postpone their travel to countries where the outbreak investigation was not able to link every case of SARS to a face-to-face contact, understanding that if that was occurring, there might be some other factor involved in its transmission. This had a serious economic impact, as you know. Canceled flights and decreases in revenue in the tourist industry and in routine sales and trade. Finally, there was one more policy decision that was necessary to be made, and this was a challenge to countries publicly when working with them through the WHO system. So this was a decision that was very difficult for the Director General to make. This was actually challenging a major country in the world because they were not reporting an infectious disease. But the Director General did that, publicly criticized China for not sharing its information about this outbreak in April, and the next day the Vice Premier was on a plane to Geneva, took charge of the outbreak, and stopped the outbreak using all civil and health mechanisms in China. Now, you can see on this graph why it was difficult to identify early on in China, because there were only sporadic cases of SARS. But then when hospital workers began to get infected, it amplified, as you can see, and it caused a major epidemic in China. This is the global epidemic. It began in November in 2002, and by the middle of July, it was over and declared finished. It was very fortuitous that this new way of working had been developed within WHO with a vision toward reformation of the IHR, which had been a rather difficult process from 1995. But because the World Health Assembly occurred during the SARS outbreak, it was an opportunity to institutionalize, if you would, in WHO language, those policy decisions which had been made and which had been great risk to WHO. So this resolution permitted reporting of infectious diseases from other sources, all infectious diseases with potential for international spread reported, and the regulations to serve as a formal framework. So what happened was the regulations went from an attempt to control at borders to detection and containment at the source by strengthening core capacity. From passive to proactive, using real-time global surveillance evidence, and from 3 diseases to all public health threats. I'm going to briefly go through what the regulations show because I'm running out of time, but this shows you the strengthening national capacities. The fault here is that the assessment is done by countries. It's a self-assessment done by countries who report to WHO whether they've strengthened their capacities, and many countries missed the deadline and are now asking for prolongation. This is the instrument that was designed within the international health regulations to compensate for not just having 3 diseases, but a whole series of diseases. And this is a decision tree developed by the Karolinska Institute, Johan Giesecke, in Sweden, which was then field tested and is used in the international health regulations. The health regulations are proactive surveillance, and instead of having to put information out in a press release, as was done before SARS and during SARS, now there's a national IHR focal point in each country in direct contact with WHO. There's an event management system into which data is entered and assessed, and this shows you the access of the state parties and the operations groups to this data, and this shows you what that data looks like, accessible to every country in the world, their focal point. So the IHR were radically changed from a passive system to one which takes reporting not only from countries but by other sources. It has an emergency committee which helps the Director General make decisions. It has a decision tree analysis, and it has national containment of public health risks, and collaborative risk-based public health measures must be done if it is considered to be of international importance, if not national containment of public health risk. Now, I'm going to ask you 4 questions because the IHR revision is considered to be a very major step forward, but I'm going to question that a bit. And my final words are, number 1, are the IHR too restrictive as they are now? Should the IHR focus more on core capacity, as David said earlier, and permit more flexibility for alert risk assessment and response? Third, by placing emphasis on the public health emergency of international concern, have the IHR de-emphasized the immediate response that's necessary and that could prevent a fake from occurring? And do the IHR provide for the community engagement and resilience required in countries where government is not trusting or functioning effectively? Thank you.
Thank you very much. Thank you for your excellent review about the IHR and the SARS outbreak. Now I invite Harvey Feinberg, who's going to talk us about how well did the IHR work during the H1N1 pandemic, the first moment when the IHR was fully implemented for the first global outbreak.
Well, thank you very much, Dr. Aguilera. It's a pleasure to be here, and particularly to have an opportunity to speak with all of you about the experience of the first field test of the new IHR of 2005 in the case of the H1N1 outbreak of 2009. David's final four questions, I think, are an excellent bridge to begin to reflect on the performance of the IHR in the course of the H1N1 outbreak. In my few remarks this morning, I'm going to try to emphasize those particular aspects that bear on governance questions, the subject of this discussion, and downplay many, many other relevant but more remote lessons that emerge from the review of the experience in 2009. Very briefly, to recap that outbreak, the first cases of influenza, H1N1 in 2009, were detected in Mexico, then confirmed in California. By the end of April, there were cases in a number of different countries on several continents. By late April, the WHO did declare a public health emergency of international concern and convened its emergency committee. By June of that year of 2009, 73 countries had reported, and there were more than 26,000 laboratory-confirmed cases, and a full pandemic, which is a phase 6 rated pandemic, was declared in June of 2009. If we look just at the experience over the ensuing year, by late April, the number of countries that had outbreaks were rather limited, but by the following year, when you looked at a global picture, there were indeed cases reported all across the globe. A question which is often considered is, was this a very severe experience or not? And the answer to that question depends on whether you look at mortality per se or at years of life lost. If you look at mortality and the two subsequent but most well-grounded estimates of overall mortality in the several hundreds of thousands, would place this influenza year below the average of burden of influenza in the world. However, in the 2009 outbreak, because it was particularly more severe amongst younger people, if you measure in terms of years of life lost, it was more severe than average in a typical year. It had an unusual age distribution in terms of severity. The experience that I'm going to share is based mainly on the work of a committee that was charged by the World Health Assembly and the Director General in 2010 to examine the experience of the IHR in the course of the pandemic and the performance of the WHO. The committee that examined this question included 24 members from all WHO regions. It proceeded through a very open process of testimony and fact-gathering, examination of materials, documents, and interviews, and ultimately submitted its final report to the World Health Assembly in May of 2011. And as has been indicated, I had the privilege to chair that review group. I would say just parenthetically that 24 was a large number of people to have to manage, and it was an interesting added task. But it turned out, I have to say in retrospect, that when it came time for the discussion at the World Health Assembly, the fact that there were already 24 countries with a representative engaged in the deliberation turned out to actually be an asset in terms of the receptivity and response of the Assembly. Now, just to highlight a few of the areas in the course of the review that produced some insights. This was the first test of the IHR 2005 regulations that David has described in terms of their evolution. The experience did reveal vulnerabilities at every level you looked, globally, nationally, and locally in public health capacity. The experience also revealed the limitations in the availability, accumulation, and applicability of scientific knowledge in responding to the outbreak. The sequence of actions and deliberations demonstrated many difficulties in decision-making under conditions of uncertainty and stress. There were many complexities in cooperation on the ground in real time that were again revealed by this experience. And particularly challenging was communication at all levels amongst experts, across policymakers, between experts and policymakers, and certainly with the public at every level. And while there were many achievements that the committee did note, it was also evident that there were a number of shortcomings, both in terms of decision-making and program implementation, that could be gleaned from the 2009 experience. I'm going to now just focus on a few highlights that, again, give us some salience to the governance questions. We've already heard about the international health regulations and their purpose and how they differ from the earlier regulations, so I will not dwell on that. The first major conclusion of the review was that these regulations, as evolved and developed, did make the world better prepared to cope with public health emergencies for all the reasons that David has already outlined. However, the second part of the conclusion was that core national and local capacities that are called for were not yet operational, and in fact were not on a path to timely implementation worldwide. And I think it's fair to say 5 years later, the same conclusion in direction, if not in actual quantity, still pertains. There were a number of things that were successfully managed because of the IHR, including the focal points as loci of communication. There were also clear illustrations of ways in which surveillance in this broader capacity did improve, and certainly the idea of the decision tool as a replacement for notifiable diseases was a very significant step forward and demonstrated its applicability here. But there are also two really critical shortcomings. The first we've alluded to a number of times. The paper requirements were simply not being fulfilled in practice. That's number one. And number two is that there's nothing in the regulations that can enforce any of the called for implementation steps. There's no enforcement mechanisms that are evident in the regulations. And so these two very critical shortcomings on top of the points that David has already mentioned, I think give us a basis to rethink and perhaps improve on the current IHR. It's very important, getting back to the questions we've already talked about, is who has power and who has authority, for countries to want the regulations to work. And if that is not engendered and it's not based on self-interest and real analysis of consequences and costs, then there's very little prospect that they will in fact be improved. But there are ways to make it easier for countries to implement these regulations, including international collaboration and mobilization for technical assistance, the sharing of relevant resources, and an improvement even further in the event information site managed by WHO, and providing of available and appropriate resources at the national levels for these steps to be carried out. It's also relevant to be able to clarify the effects of decisions made by countries in the course of their implementation of the international health regulations. Second level of conclusions about the World Health Organization is that the organization did, in fact, perform in many ways successfully. However, it confronted systemic difficulties and demonstrated certain shortcomings. And I want to stress these systemic difficulties for a moment without belaboring the many successes that went on in the course of the epidemic. And really, I want to stress 4 structural problems that besets the World Health Organization today. In her very becoming and charming way when she introduced herself, Dr. Chan said she is the servant of the World Health Organization. That is true. The question is, who is the master? And the challenge for the World Health Organization is at once, is it responsible to the member states who comprise the World Health Assembly and who authorize the budget and who define the agenda and who set the pace? Or is it responsible to the people of the world and to the health and well-being of humanity, which is its larger mandate? And this tension between an entity that is intended both to serve the health of the global population and the needs and interests of the member states is a continuing tension for the organization. Secondly, no matter what else we may expect in terms of authority, responsibility, delegation or otherwise to the World Health Organization or any other entity that may be created, if the budget available to the entity is incommensurate with its responsibilities, you have a mismatch that cannot be overcome by human goodwill. And so the incommensurate budget relative to the scope of responsibility is a second structural impediment. And we won't belabor here the difficulties engaged in the current model of financing for the World Health Organization. Third, and this is particularly critical when attempting to create a governance structure capable of responding to more sustained and more nearly global outbreaks rather than very focal short-term emergencies, such as a number that David described, or by contrast, very chronic, low-grade, or relatively constant health problems that burden the world population. But how do you also manage to mount intense, sustained, and global responses in a dynamic pandemic? This was a huge challenge for the World Health Organization. It was forced to rely on volunteerism from within. It was forced to rely on repositioning of people from essential functions to emergent functions. And it is inevitably placed in a situation partly connected to its financial resources, but also connected to the human capacities built in of a mismatch between its available capacities and its ability as an entity to respond and mount an intense, global, and continuing response to a dynamic pandemic. And finally, something which also became even more manifest as a challenge in the Ebola outbreak is the separation of authority and autonomy between the regional offices and the central office of the World Health Organization. As you all know, each region has its own director, separately elected by the member states of that region, and the ability to offer a command and control management structure globally when you're confronting and dealing with a set of autonomous regions is a very difficult structural challenge. So all of these I wanted to stress because I think they have real bearing on choices and deliberations that will be made about governance. I won't go into here some of the particular issues around influenza pandemics, around the definitions and around communication. They were very relevant in the 2009 context, but perhaps less relevant to us thinking ahead from the point of view of governance writ large. Now, there were a number of specific lessons around pandemic processes and guidelines, particularly in relation to influenza. But what I would like to finally stress in these comments is really the overall conclusion of the review panel and some of the implications, again, for governance. The world, the panel stated, is ill-prepared to respond to a severe influenza pandemic or to any similarly global, sustained, and threatening public health emergency. And it's that reality which has to stand as the core challenge to all of us thinking about a regimen of global preparedness and response capacity to deal with such emergencies. And I would just summarize by saying beyond pandemic influenza, among the elements that come out of that experience that have bearing on our continuing deliberations are first the structural impediments that I already mentioned on mandate, on funding, on organization, and on the center and regional relationships. The limitations in implementation rather than in structure of the international health regulations and national response capacities. The fact of need for actionable data monitoring and management of systems over time. The challenge of communication and coordination in the multifarious models of global actors that we have seen that depend both on national and NGO actors. And finally, on the definition and management of the capacity and protocols to mount and sustain the needed comprehensive responses to outbreaks that are themselves global and sustained. This requires a full array of resources, and it requires ultimately a unified command structure in order to be able to carry out what is necessary to protect the world's health. Thank you very much.
Thank you, Harry. And the last speaker of the second part, John Liu, President of Médecins Sans Frontières, is going to speak us about Ebola as humanitarian and healthcare crisis, governance challenge as seen from the view of a key NGO.
Good morning. This is going to be a presentation of how, from our organization, we went through this Ebola epidemic. I was told to be evidence-based, and I'm afraid I'm going to be experience-based. So enjoy the ride. This is going to be the presentation with the least word and a lot of pictures. So just a reminder, and then knowing that Peter Piot is in the room, but we all know the last 20 years we had several outbreaks, and the biggest one had 425 cases, just to keep things in perspective. MSF, we were there in many of those outbreaks, and for this one, we were there in several, I would say, locations, 16 centers that were either Ebola center or transit center. And so what we did, for this Ebola, we did what we did for the past one, which was to act on what we call the 6 pillars, which means it's caring for patients in isolation, making sure there's access for healthcare. But then there's, in the between that, is all the activities around surveillance, which is contact tracing, awareness of the community, alert, plus a safe burial. So we tried to do that, and we realized very quickly that we will not achieve that because it was so widespread. And so just as a reminder, as of today, we now have hit the 28,000 confirmed cases, and about 15,000 of them are confirmed, and we treated 30% of this MSF. So why do I bring this? And that's going to be I think the only graph I have, is I just want to bring to your attention on week 18, when we had this lull of cases, and when we thought that we were out of the woods, and then all the wishful thinking that it would be the same business as usual, only a few weeks, and we were mistaken. The other place I want to bring your attention is on week 44, where basically what we realized is the big drop of cases in Liberia, and that actually the cases happened before the huge deployment of the international mobilization. So just, it gives us a bit of a humble take on all that. So phase one. So I've decided, the way I looked at it, I've split it in 5 phases. So phase one is the usual part that it goes undetected. And then most of the time it goes for a few weeks. The average about 8 weeks in the past. This one was a little bit more, it was 12 weeks. And I guess this is where possibly IHR, strengthened IHR will play a role, because we could possibly be able to contract this undetected phase, possibly. I think the phase 2 has been for us the hardest one, and because it was basically screaming in the desert for 6 months. And this was very, very difficult. And it's just as a landmark is the fact that when we did that, you know, we sounded the alarm publicly, and we sounded the alarm in the backstage as well. And so we tried to, I would say, push some leverage in terms of what people call the political interests. And as I always said, and it's one of my favorite quotes of Charles de Gaulle is, states don't have friends, they have interests. I think Ebola was a good example of that. But just what was clear to us is throughout this phase, we lamentably, I would say, failed because we did not prevent what happened. And so these are the challenges that we found during that period. And I think there was a lot of challenges in terms of surveillance, the widespread infection, the burial, the R&D, and the response. But I think the one I put in highlight, the yellow one, or the one that I think we could have a control and could make a difference next time around, especially if we prepare ourselves better, and then if we have some sort of, I would say, standard of operation in terms of how to respond. But there's 2 things I want to bring your attention to, and I always say it because I guess I lost so much sleep over that. It's about the community mobilization. And I really do think that we fail lamentably, terribly on the communication and in terms of with the community, in terms of the content of the message we're bringing to them, because we told them that it was a deadly disease, there was no treatment, that you would be cared in isolation away from your loved one, and there would be some spacesuit men around you. I'm just telling you, it just doesn't work. It's not sexy. It's not a drive to come and consult in the center. And the other thing that I think was a big mistake is the fact that we had only a one-way conversation with the community. We basically lectured them, but we didn't listen to what they have to say and what they needed and what they were not understanding. I think the other big thing, and I think all of you have highlighted of all the other speakers, is the vacuum of leadership. And it's this has been there and needs to be highlighted in terms of national leadership and as well as international leadership. And of course, you know, every time there is those kind of crises, there's always a denial period. And then finally we go into recognition. And sometimes I think there was a question of recognizing the severity and then what goes into action afterwards. And that is, for me, our goal, is to contract that period of 6 months that we haven't managed to. But one of the things I have to say, and that's really my personal take on that, is I think that the fear factor has been really, really a huge variable that has impacted the way people wanted to mobilize. And we don't want to say it, but everybody was dragging their feet to come and play a role in this epidemic. So MSF, we reached our limit. We've told the world. By July, there were 1,400 cases, 800 deaths. And then so we did what we usually do. We speak out. That's the only thing we had to do. We kept caring for patients. And then back then, you know, I would just say that we were doing an average of 400 interviews on a daily basis. I was doing interviews around the clock. And the thing is, it didn't work because otherwise you will have heard the message. And so I've done a master in management. I remember my teacher telling me, Joanne, if people are not listening to you, it's because you got the wrong narrative. So I was having the wrong narrative. So I changed my narrative. And so we went into from the global fear to some action. And I would just say, I was told that last week in Atlanta, people said they felt my pain. And it was awfully painful. And I'm just going to tell you, and I don't want to do a psychodrama of that, but it's just, you have to know that this could have been avoided. We could have avoided a catastrophe, and we didn't avoid it. And I just want to remind you, for being an NGO who was at the forefront and having to turn back patients who were infected on a daily basis, and every morning having to pick up in front of Elway 3, 1,000 patients dead at the doorstep, to open the center in the morning for 30 minutes just to fill in the bed of people who died overnight. I don't want to repeat that kind of history. To be stopped to not put IV on my patient because I am not able to care for them because there's too many patients, and the only thing I'm managing is putting them in a bed, in a clean bed. We just cannot afford to repeat history. And that's why I'm here today. That's the only reason, because I'm committed to that. So, finally, WHO comes into play. We wish you'd have been there earlier, Margaret. I've met you with you, we talked together, we've solved that together. But, and I must say that, calling for the public health emergency of international concern, I think was key. And then when I looked at it, I'm not an expert of that, but, I went to the web and I looked at the checklist. And the reality, we were filling the criteria way much earlier than July 2014. So, but the thing is, the reality is there's no statement that's going to save life. And it's only action that's going to save life. And then, although we made that statement, we were not ready to act right away. So we went rather into a global hysteria about Ebola. And I think there's some good in global hysteria, because by having the first case of the US citizen repatriated in the US, well, the big nations just said, oh my God, it might come to our place, and we might have to deal with that. So it's not about me, but it's about what I said. I don't like to speak at the UN. I find it nerve-wracking. But what I wanted to clarify, because we've done something that MSF never do, is to go and brief the UN General Assembly. That's one thing. But we've made call for things. And then some of the things we said in that speech, and I remember, going through my speech and I said, what I'm going to say. But we just said, we lose the battle. We have lost the battle for the last 6 months. But the reality is we can win the next 3 months. That's what I said. And then we did a priority list. You know that MSF, we're never prescriptive. We like to whine. We like to criticize. We're never prescriptive. We've done it. We've done it. I take so much backlash for that. We asked, for more Ebola isolation bed. We asked for a large workforce, including military asset. People will never forgive me about that. I didn't ask for military intervention. I asked for military asset. Because I thought that we needed a massive deployment of workforce with a good chain of command. And then we asked, especially I think that's what the military can bring in terms of added value. It's air bridge and as well medical evacuation. And then we wanted as well bed for health staff. And so what did I learn from that is the fact is, as soon as you call and you use the word military, people think you want a military intervention. So that's one thing. And the other thing is once you bring it to the UN Security Council, all of a sudden it falls really into the realm of security and protection. And then you don't talk about patient anymore, but you talk about safety. And so I think that was a bit something that I'm taking on board for the next time around. And hopefully there would not be another one. So yes, we were pushed beyond our limits. We've told the world, we kept telling them. And I think for one of the things, and in the memory of all my colleagues, we had 28 staff who were infected. 14 of them died. And as I always say, is there's no context in the last 10 years where we lost so many staff. So this is something. And in terms of challenges, and we tried our best and we tried to be innovative. We built a big ETU because we thought that bigger was better. Maybe it was not really the reality. We did as well what were the two things that we never did before. We did the household distribution of disinfection kit. And I think that I don't know what is the impact of that. But I think that you cannot ask people to change their behavior and not giving them something to change their behavior. So the kid had gloves, the kid had disinfection solution, the kid has a body bag. But the thing is, you have to give them something that they can do something about it. The other thing is we did a massive anti-malaria treatment to 2.5 people because we just say this is the other confounder, malaria. And then again, I don't know the impact of that, but I think that it might have been useful. So, and the other thing that we did as well is wow. So I last night I was trying to shorten my presentation, but the other thing we did as well is training, and then we did some massive training. And one of the things we kept asking ourselves is, should we have trained earlier more people for the multiplication effect of having more people being deployed? And should we have become MSF somehow, I would say, the training, I would say, unit for the world? Because we were one of the, I would say, entity who had the know-how how to treat. And this is something that we haven't came our head around it, but we are wondering. So, phase 4. Cases started to decline. Great. This is good. And then how do you keep people mobilized? But one of the things that was this is we needed to change our strategy, and we were slow to do it, MSF and the rest of the world, because of what I've asked in September. People were still trying to implement that in December, because it took at least 2 to 3 months for most of the big, I would say, nation to deploy in the field. And so the reality is, once the number of cases deploy, we have to go from, I would say, a massive ETU to mobile quick response. And we were a bit slow to adjust to that. The other thing we did clinical trials. This is not something MSF do. Most of the time we let that to other people. And then since we're not I would say, familiar with that, but especially in this kind of health crisis, we partner with people. So we learn to work with other people. This was as well a learning curve. But I would just say that what was key, and then we've been criticizing so much WHO, so let's give them some praise for a few things. And I think one of the things that WHO has done in August is confirming the use of products that were not tested on primates, and then help us to frame and fast forward the research and development. And I think this was key, and this was necessary. I think it's a good precedent for next time around, and so we should just keep that in mind. Phase 5, this is where we are right now. This is the long sprint to zero, and then we know that there were a case after several days back in Gambia, yesterday in Sierra Leone. So there's going to be ups and downs, and I think it's going to take a while, but what is really, really important is to stay focused and committed to bring it to zero, and not switch right away into the reconstruction phase, because this is one of the things that we've done for Haiti. Is the earthquake was over and we all moved the money and the manpower for reconstruction. It's not over yet, unfortunately. And even if there's only a few cases, it's not over. We need to remain there, and then we need to continue in terms of what we have to do. One of the things I would like to say is the fact about survivors, and I was talking about the pillars of activities. One of the things that we didn't take into account was the survivors, and the fact that survivors are patients. And then basically today we don't have program really for them, and we don't have budget line for them. One of the other thing about survivor that I would like to put forward is really the fact that there's a really what I call the vampire effect right now. Is we want survivors and use their blood to figure out how long they're going to keep the viral load in them in all their body fluids. But the thing is, we need to bring them, I would say, a comprehensive approach. And so we need to give them, medical care, but social support, and making sure they're able to integrate, their community. So, but just not taking their blood for us to understand better the disease. So yes, recently we have some good news about vaccine, and MSF was part of that. And I think now the challenges is to find out in terms of to make sure that it's going to be accessible, especially if we have other little surge of cases, who we're going to vaccinate and who's going to have access to it. Find out about stockpiles, because I still don't know how many vaccine there is left, and then making sure there's going to be as well other candidates for as a vaccine, because I don't think that only one is good enough. So what do we know? You know what? We don't know that much. We think we know so much. But as MSF and being treating, you know, several thousand patients, I'm still going to tell you that I don't know much about Ebola. And then and we've made a lot of mistakes. And I think it's been one of the most humbling, I would say, context of intervention for MSF. And so, but what we know is the big ETU is out for us. We know bigger is not better. I think there's a critical mass of around 100 beds. We know that survivors now need to be straight from the beginning part of pillar activities. But as well, I think that one of the things that when I think about that is the fact that it's about the community. And we know that Ebola starts in the community and will stop in the community. And so we need their buy-in, and they need to be part of the dialogue. And they cannot be only some people that we inform once in a while of what's going on. And the other thing that I know is, I guess I should have spoke out much louder, me and the rest of my team, because you didn't hurt us for 6 months. So I'm taking that on board. I think there's a lot of word about IHR, and it's all about IHR. You know, my two predecessor speaker. And I think the main thing about IHR is, yes, there needs to be incentive, but I think we need to ask ourselves the hard question, and why was it not implemented? And I think that beyond the fact that incentive is, we need to accompany countries to do it. I just returned, you know, from West Africa 3 weeks ago, and I asked them, I said, you know what, the world has been now in your country, you know, doing surveillance, putting lab. I said, are you ready? Are you filling up the criteria for IHR? And they all looked at me and said, not at all. Do you understand that the world has been in West Africa, and none of them are apparently close to fill up the criteria for IHR? So you know how far we are to get there. So my sales pitch for R&D is the fact that the colleague from veterinary just said we need to use the peacetime. I call it the downtime. But basically, this is for me a key tool. Beyond IHR, this is a key tool to be best prepared the next time around. We need to have, you know, a priority list of what are the emerging infectious diseases that we have to do. I would say the upstream research, and make sure that we get through the phase 1 in terms of research. We need to somehow pre-agreed on designs of trial and not agonize like we did last time around that delays us for 3 months. And so we need to agree on what is ethical doing such an emergency, and is placebo a real deal? Can we do that, you know, when people are dying and when the case fatality rate is between 50 to 70%? So, you know, we are fully committed, MSF, and then we are fully committed as well to share our knowledge. And this is why we would like to create a biobank and make, I would say, digitalize all our clinical data on our patient and match it, you know, with the specimen. But the other thing is, we are as well building, and Welcome Trust is one of them, but the open data sharing platform, because we need to be transparent about what's going on, and we need to be able to access it. So, are we ready to learn? And you know, I've been going to multiple of those meetings in air conditioning with good food and cookies. And so the reality is, every time people are telling me, you know, we'll, you know, never again, you know, this really feel-good rhetoric. And the reality is, we do spend a lot of time, you know, talking about the means. I consider WHO a means, the surveillance, the epidemiology. But I think that we need to make sure that that our, you know, I would say outcomes will put in front and a focus on population needs, and not only on reinforcing systems of response. That's, for me, you know, important. And the global response cannot be only triggered through the lens of protections and country safety. So I really do think it's key. And then the other, you know, I would say thing that we need to somehow, I would say, and that's, I think that's our homework, is to find the right balance between the private sector and the public sector. Because the reality is, philanthropists and MSF, as an international private NGO, we are not accountable to the health citizens. We do what we have to do. People who are accountable to the health citizens are countries, our government. So we just have to keep that in mind. And then we just cannot, you know, I would say, put at the same level that being sick is the same as being insecure, you know, when we talk about the response and the biggest picture. So, looking up into the future, I think the two big, I would say, elephant in the room for me for this Ebola epidemic has been the fear factor and the politics. And so we have to acknowledge that. Most likely next time around it won't be Ebola. So guys, we cannot cut and paste what we've done for this one. I think that, so I've said it over and over again, it is not a failure of means, it's a failure of politics and political will. And so we need to have the political will to act. We need to have the political will to force transformation in WHO, and that's in the hand of the state members, like it or not. And then we need to have political will to keep the patient in front of the response and not only reinforcing the systems in the response. So, and that's for me the way and the only way that we're going to be able to contract a phase, I would say, 2 that was from 6 months to 6 days. Thank you very much.
Excellent. Please have a seat. We're going to have more than 40 minutes for discussion. I like to congratulate the speakers for excellent presentation. We have seen in 12 years how an idea was raised, fully implemented, and failed. So we are going to discuss if we are going to be able to learn, not only if we are ready to learn. We are going to be able to learn of these lessons. So we have many people that request the floor before the break, the coffee break. The first, I'm going to ask if they're going to keep, not. Okay, is Daniel Lopez Acuña. And please rise them. Oh.
Daniel, it's on. Daniel, could you give your name, please?
Yes, my name is Daniel Lopez Acuña. I worked for 30 years with WHO, and I retired recently, and I'm an independent public health expert. I just wanted to raise 2 points, one in connection with the discussion in the morning and one with the discussion now. The one in connection with the discussion in the morning is following what Jimena Aguilera was just saying. Are we going to be able to learn from history and from mistakes and right things? And let's put this in perspective. We cannot address the governance issue unless we address the political economy of governance. And this is a factor that we need to put in the center of the discussion. In my perspective, in the last 20 years, the international community and some political powers more than others have fostered a proliferation of global health actors and have created, one way or the other, a balkanization of the global health architecture and the global health governance. Do we want to continue in the same line and the same direction? Or shall we strengthen, rationalize the global health architecture and strengthen the true collective action mechanisms that we have, improving what we need to improve, but not recreating or reinventing the wheel? And I think this is a debate that has to take place. Because, yes, we can rethink some of the global public goods or collective action mechanisms with engagement not only of governments but also of non-state actors. But we don't have to necessarily erase them from the face of the earth to try to recreate the wheel and even reinvent them wrongly. Second point, with respect to the discussion that we just heard, and especially in connection with Janet's remarks. Again, we have to get the diagnosis right. If with Ebola we witness, for one reason or another, a history of late awakenings of many systems, of the global alert and response system, of the humanitarian system that goes beyond health, of the international global security processes. Are we going to say that this is a problem of structures or governance, or we need to look at the problems of coordination, of leadership, of accountability, and then do the fixes that need to be done in that regard? I think the fundamental lesson that we need to learn, and I agree with the point she made at UN in New York, is we need a global system where we can have a swift mobilization of civil and military assets of public health, clinical and logistic teams, and this can be led by the World Health Organization and can be built with another process of consultation. But we don't need to disregard or disestablish the good things that we already have in place. And I think it's very important to get the diagnosis right. Thank you very much.
If you prefer, we can take a round of questions and then, okay, the second one is Oyewale.
Thank you very much. And thank you for, my name is Wadi Tomori. I thank all the presenters. Oops. Okay. I thank all the presenters for both the morning session and the 5 speakers. One thing that came clearly out for me is that the emphasis should be on the people and the countries. But having said that, commenting from what David said and what Margaret said, the IHR was something that had a foundation in the, quote, colonial era. And the attitude of countries that don't have power is still based on that. They see the IHR as saying, keep your disease within your territory. Don't bring it to me. And the self-interest, which I think is unfortunate, because of the same mistake we made when HIV came. And they said HIV originated from Africa. And then we spent 3 years debating, fighting amongst ourselves, that no, it didn't come from Africa. Meanwhile, HIV was spreading amongst us. So there's the need for those people to change their attitude, to think of all those issues. The other point that came to my mind was that how come with OIE they seem to be more successful with regard to countries reporting than IHR, yet both of them have the same type of effect. The IHR, for example, if you are transparent, it's of disadvantage to you economically. On the other hand, the IHR, if you are not transparent, it's also of a disadvantage to you. How do we get the two? I mean, how do we learn from those? And I think one thing that came out of that was found that OIE people in OIE are more technocrats. Who attend the delegates to OIE are more technocrats than the delegates who go to World Assembly who are politicians. We talked about systems and architecture. Assuming we talk about structures, they are made up of people. And I think one of the greatest errors that I still think about is that if we don't focus on the people, if we don't focus on identifying that people are responsible for what, that's why Margaret Chan will get blamed for what is happening in WHO. When in actual fact, the person who should be taken to court is the WR in Guinea and the Minister of Health in Guinea. If we take people who are responsible are the ones that we take sanction them or make them responsible, then we'll be in a better situation than we are. Finally, WHO has challenged countries at different times. I don't think they're using enough of their powers. Until WHO challenged Nigeria in 2008 about polio, we didn't begin to get our acts together. These are some of the things that I think we need to do. Finally, I think this meeting, unfortunately, should have had the African leaders here to listen to what is happening. Thank you.
Mm-hmm. Thank you. Excellent. Tekemi? Please, Mr. Tekemi.
John, I was very impressed with the wonderful presentation. Specifically, you mentioned that the global fair to action is one of the phases you clarified. in this process, it is quite sure, in your conclusion, you mentioned that the political will is the key. And then, when we recall the history of the international communities, how we, cope with the risky infectious diseases in the past. David Heyman just mentioned in the case of the SARS, and the Harvey Feinberg mentioned H1N1, but we had the large experiences in the end of the last century, the HIV/AIDS. And in case of the resolutions were accepted by the Security Council of the United Nations for such sort of a risky infectious diseases, at least 3 times, right? The 2 times for the HIV/AIDS, and this time for 1 time for Ebola outbreaks. But in case of the Ebola outbreaks, the size of the size of the deaths of because of the Ebola was still the 12,000. It's a really large size of the deaths, but in comparing with the another cases, the death size is not such large. But those are the policymakers at the global level felt some sort of a fear of the future risks of those infectious diseases and took action to accept the resolution at the Security Council. This is the really process of the politicization. And then why this sort of process happened in UN decision making in case of the Ebola, but not happened in the SARS and H1N1. This is a very important, I think, that the point we have to carefully think. We have to utilize those the timing and essence to politicize those issues at the higher level of the decision making of the United Nations. But how we can design for it, it must be a very important subject. And also that the security is a very key issue for us. The journal mentions that we have to utilize the military assets, not military interference, but how when the policymakers recognize infectious diseases as a part of their own national security, then they become to notice the importance of the collective security for infectious diseases. And then finally recognize the importance to achieve the human security. So the security approach may be very, very available to politicize in the most efficient way and invite the policymakers to involve into such a very important decision making to design more efficient political scheme for the consortium of the United Nations system, including WHO. Thank you very much. That's my
Okay, a first round of response after the second round of questions. Want to have a reaction on the comments or questions? No?
I'll make a few comments. One was on what Danielle said about the global system. And I think WHO is working on a plan on a global health emergency workforce, and hopefully that plan will not just bring together the pillars, the civil society and industry, working side by side with WHO and its partners, but also it will help WHO not need to build up non-sustainable staff at this point in time and depend more on its international partners to do the response. So I think there is talk at WHO about doing that. Margaret will certainly be able to say more than I can about that. And the other thing is what Wally said, which I think is very, very interesting point of view, and it shows why we do need to have more developing country participation in these meetings. Because I believe that that is right. The IHR are seen as a colonial tool to keep your diseases where they are. And that risks to be the failure of many other initiatives going on today, including the Global Health Security Agenda. But that emphasizes even more why WHO is so important. because WHO is where the countries have their confidence, and WHO is what should be used to make sure that the strengthening of capacities in countries is not seen as a colonial vestige of keeping those diseases out of my own country.
Thank you. Jan, you want to?
I remain, you know, I would say divided, but I do understand, you know, about the security approach and there needs to be something that creates an interest, and then this is what anyway government are there for their nation and for the security. So I do understand that. I just don't want this to completely hijack, I would say, the agenda in terms of how we craft the response and making sure that it remains people-centered, and that caring for patient or infected community being infected is not what I call, I would say, a convenient side product, but it needs to be carved in at the center of the response, because otherwise, and I think that, David, you've written a great piece on that, on this, the safety, the individual safety and the collective safety, and it's you just cannot abstract. The collective safety is actually the sum of the individual safety. So I think this is on what we've been agreeing the most, actually, since we know each other. So, but I really do think it's important to keep the patient at the center. I just want to clarify something, because I really do think that in this in how we want to craft a response, I really do see a role for the WHO, and I've been one of the most person who has criticized the WHO. I think the WHO has been a convenient scapegoat throughout that crisis. We're all very happy to find someone who can just take up all the slaps, and I think that we should be aware about that, because it's way too easy. On the other hand, you know, there is some fault and there is something that should have been better, and then we will not ignore that. But on the other hand, I think for me, there's some people that then step up to their responsibility. And talking about the South voice or the South being there, I totally agree with you. And I think I find it a bit a scandal today that we don't have more the voice of the countries who are affected, and that they are the one who've been at the center, who went through it. And I think it's, again, you know, the same for me, I would say lesson learned from the communication with the community. We're going to come up with something, and we're going to lecture them again about how to do things.
Just two very quick comments. The first is, whatever governance structure emerges, a real challenge will be to combine sufficient representation to have legitimacy and sufficient capacity for decision and engagement of the necessary power to carry out acts. And a structure that's a successful governance will need to include both aspects in order to succeed in the long term. Second observation, a number of people have spoken about gaps in leadership, and they are very real. The point of governance is not to substitute for effective leadership. It never can. But I think it's still important to have a governance structure which allows leadership, when it exists, to exert itself in the most constructive and effective manner. So it goes hand in hand between good governance and effective leadership.
Okay, we're going to begin a second round. There's a lot of people that request the floor, so please be most concise that you can. Rima. So Rima, you take 4 questions now, and for the second comment.
Yeah, I'll be brief, especially that I think my question, if I understood Dr. Tomori's comment and David's answer, maybe was answered. But first I want to thank the 3 speakers. This was really phenomenal. And Joanne, even though I heard you last week, maybe last week I felt the pain, but you know, hearing you again, going through the experience was very, very helpful to get some thoughts around it. So first, I completely agree with you and with David in terms of how important building core capacity is day-to-day, laboratory and surveillance to be able to get data, find out what's going on and act faster than collectively we were able to. And one of the things that we're doing, that we still have staff deployed in the 3 countries, is exactly that, response to Ebola and transition to core capacity so that we can leave behind, as you said, more capacity to do that. And so the question then, to be brief, to David, is I heard you say, are the revised IHR too restrictive? And is that, what do you mean by too restrictive? While I agree on focus on building core capacity, was it what Dr. Tomori alluded to, and is it this aspect of reporting, or is there something else that you meant by that?
Okay, thank you. Jennifer Gandhi.
So my comment is sort of in response to David's presentation, where he really nicely showed how data is such an important tool for us. I've always said that data will be what prevents the next pandemic, and public health is really a field that is built on data, or was built on data, but where I think we've grossly fallen behind. There are some parts of the world where we simply don't have the ability to collect data. There are parts of the world, like British Columbia, where I work, where we have a closed, bureaucratic, broken system that doesn't talk to any other systems and doesn't collect any context beyond simple case counts. Meanwhile, you're seeing data and open data and access to data transforming the rest of the economy in all sorts of ways. So it seems to me that in the question of global health governance, maybe there's a niche or a hole or an opportunity here where, if you're going to be a global health governing entity, you need to be doing something that no other entity can do on its own. You need to be occupying some sort of unique niche. And it seems like one of those unique niches could be as a sort of global data steward. So it would involve consolidation to a certain extent, where you would need to determine what types of data you want to collect, and this would have to extend into One Health, wellness, cultural data, demographic data, climate data, natural disasters, social media, news, you name it. But build a tool that could be used globally, that I could implement in Vancouver, that could just as easily be implemented in Gekidu on a smartphone. And you need to be the entity that creates this system, that ensures it's being used, but more importantly, uses it to find new patterns and lets data, rather than agendas or political will, drive detection and drive intervention. So I think that while it's a bit of a consolidative activity, it's also an expansive activity, in that it would really open up collection and use of data in response to individual communities. So is there a role for data, big data, I hate that term, and open data in this next era of global health and global health governance? And what do we need to do to make that data accessible, open, and usable?
Thank you. Dr. Gostin?
Yes, it was an excellent panel, and I just have a short question for each of the panelists. Harvey, your usual very, very wise comments, I learned a lot from them. One of the things that struck me was the idea of a unified command structure. And what are the capabilities for that, and what are which institution fits those capabilities best? Is it WHO? Is it more broadly the United Nations? I'd like to hear your thoughts on that. For Joanne Liu, I mean, you and MSF, I think in all of our views, certainly mine, were the heroine of this Ebola epidemic. But going forward, what should the role be of a civil society organization, and what responsibilities should you have vis-a-vis institutions within the UN family and elsewhere? And then finally, for David Heyman, David, you've I think make a compelling case for trying to have a nimble, flexible response force that isn't permanently embedded but would be useful to go forward. And I know you've been very thoughtful about the role of GORN. And so I wanted to know, how could we make GORN more effective, more legitimate, with sustainable funding, and just what role it could play going forward?
Okay, and the last one for the round, because we're going to begin to forget the question, the comments of Chris Elias.
Thank you. I just make a few points, one negative, two positive. The negative one, I'm very struck by Joanne's presentation. It was a year ago today that the Gates Foundation finally woke up to the Ebola response, and how we miss not only MSF voices but others. My interpretation of that is that in the absence of a clear framework for engaging non-state actors, we weren't engaged. A major donor, somebody not shy to use its political power and voice. And we had made a couple of reactive, modest-sized grants to the Ebola response over the course of last summer in response to requests. But it really wasn't until a year ago today I got a call from my friend Awa Kolsek, the Minister of Health in Senegal, who said, "Where are you guys?" And I said, "Well, what's going on?" And I said, "Well, we made some grants to UNICEF and WHO," and she said, "That's not enough." And within 48 hours of that call and some more investigation, we got authorization from Bill and Melinda to spend $50 million, and within 2 days we'd spent 15 of it to help mobilize some of the early responders, the late early responders. So my main point there is that, and ultimately we seconded 12 staff to WHO at Geneva and Freetown and Brazzaville. There was a missed opportunity to engage us much earlier because we weren't in the data flow, to Jennifer's point. My two positive comments are that there's a lot we can learn, about progress we've made within the existing governance structures. And I think there are two examples I want to give. One is the other public health emergency of international concern, polio eradication. In the last 3 years, after being stagnant for a decade or so, we've seen incredible progress. We're now over a year since the last case of wild polio in Africa. And if you look at some of the innovations there, one was about data. We put together a unique data sharing agreement with Margaret's help for the key partners of the polio response to be able to share data in real time, with some nervousness about some of the sovereignty issues. But in order to craft the kind of endgame response that was necessary in Nigeria and that is now trying to be replicated in Afghanistan, Pakistan, it's taken real-time, immediate sharing of data among the countries and the partners, et cetera. And recently the Pakistanis have visited Nigeria to learn how to use that data more effectively in their response, and we're in the final stages. The other thing that we learned was the importance of command and control, which in the case of polio has been instantiated through these emergency operations centers. And that, I think, Dr. Tamori played a role in the repurposing of that infrastructure for the Ebola response. And I think it was, frankly, Nigeria's leadership and ability to take an already mobilized command and control response that helped mean that Nigeria had 19 cases and not the kind of situation we saw in the Mono River states. And then finally, to one of Joanne's points, one of the key learnings, and it's surprising it took us this long to learn it, in the end game of polio has been the importance of the community mobilization. And frankly, communities were tired of 11 campaigns a year of polio for a disease they no longer saw anymore. And so diversifying into meeting community needs through health camps and other more comprehensive approaches has reduced the refusal of vaccination and improved the turnout and has, frankly, I think, made part of the difference in this final stage of polio. The final thing I'd say, the other example is on R&D. Back in 1998, West Africa saw the most devastating outbreak of meningitis A. In response to that, there was a call from African health ministers in the assembly to develop a solution, a vaccine for meningitis. That was responded to by WHO through a partnership that the Gates Foundation was happy to support way back in 2001 to develop a low-cost meningitis A vaccine. And there's a lot of innovations there in the governance. David was part of that governance, where it was a partnership between WHO and PATH, where the Gates Foundation provided the funding. And PATH basically managed the public-private partnerships, all of the contracts with the private industry. But the project was governed by a joint management committee that set the vaccine development strategy, the resource allocation, et cetera. But once approved by two ADGs of the WHO who sat on that governance committee, once the strategy was approved, then the non-state actor partner was free to go and do what they could do much more easily than the WHO can do in terms of working with private industry, arranging tech transfer, et cetera. And so there's an important innovation there, now over a decade old, that's led to a 40-cent a dose vaccine that's been given to over 400 million people in West Africa, and has had a tremendous effect in reducing meningitis A. What I hope we do in terms of the R&D response is, back in 1998, we came up with a specific solution to solve meningitis A after a bad outbreak in West Africa. And it would be a shame if we come back this time with a specific solution for Ebola. We have to come back with a broader, more comprehensive response to how do we innovate in the governance of these R&D efforts so that WHO can be a part of it, even if it can't totally execute that on its own because of some of the challenges of working with private interest and commercial interests, et cetera. So I think there are some interesting incremental innovations around the current governance structures that we could learn a lot from, both in polio eradication, meningitis A, some others, that might prove to be an interesting template for a more comprehensive governance reform going forward.
Okay, I'm going to open again for the comments of the table, but focusing on the areas of governance, the governance impliance of every comment that you have made, and how do you think that it could affect the ideas or the new developments that we had to strengthen the IHR or modify it, or to strengthen the role of WHO or support it. Begin for this side.
Start on this end.
Yes.
Thank you. I'll just comment briefly on the question of a unified command structure, because I do believe that in whatever governance model evolves, if it's going to succeed in being adaptive to the next emergency, which we cannot currently anticipate exactly what it will be, but we believe it will require a sustained, potentially global, and rapid response. A way to achieve that which is relatively efficient and not diffusing of resources and not delayed is to have pre-positioned, predetermined, delegated, time-limited, constrained authority which nation actors and as many of the non-state actors can agree will go into effect under stated conditions, in which you'll have a unified capacity to deal with materiel, people, transportation, communication, local relations, and the deployment of really critical essential resources, whether that's emergency hospital structure, drug and medication, support elements for community, water, food, etc., or whatever is required. The drawback of not having this structure is that you have lack of communication, you have delayed response, you have different entities proceeding in parallel or sometimes in overlap, and you leave out parties that could contribute a lot but don't have a way into the unified structure.
Yuan?
To respond to the question on the role of civil society that was asked to me, I've been, over and over again, asking myself this question, because I agree that I think there's something that can be harnessed that is not harnessed, and as well there's somehow a multiplication right now of civil actors, but with good intention, but very, very limited capacity and know-how. So how do we reconcile that? And so what I was the reason why I was asking, for civilian and military asset is just because in some countries you have civilian, I would say, workforce that exists. I know they exist in Europe. The other model I was thinking, I was discussing that last night, was with Harvey about if we were thinking right now of the movement of the International Federation of the Red Cross, for example, who are developing the emergency response unit. The Nordic country has done it. I'm going to talk about Canada because I'm Canadian, but they are doing it as well. And the reality is they are really, really keen to have, I would say, a trained pool of people. Because right now the main issue about when it comes the time to deploy is the fact that it's to deploy in big numbers with a good chain of command.
Yeah.
And so if you don't have people that are somehow a bit I would say, brief and trained, you will get n'importe quoi. You will just get, a free-for-all. And so for me, it's really important. But I think there is something there that needs to be harnessed. And I think that for the R&D, Elias, I agree totally with you. And then this is why we've been advocating MSF in terms of how can we fund R&D and link it to the market. And so can we create a sort of an international big funds or something like this? Because we otherwise, diseases that don't have a market basically don't have any incentive to have develop a research and development. And so just to finish as well, is MSF is not the hero of the story of Ebola. But I would just say the people in West Africa are the hero of it. The other one, day and nights, who are for the last 18 months have been fighting Ebola. And I have staff in my center that have been there since March 2014, that every day they go there despite the stigmatization, despite the fact they have lost loved one, and they want to kick out Ebola from their country.
David?
Thanks, Jimena. Just a few comments on what Rima asked about why do I think the IHR are too restrictive. I think if you look at what's going on in the world today, the world is waiting for a fake to be announced before responding. This has happened in MERS, coronavirus, which continues to emerge, continues to spread, yet everybody's waiting for a fake to be called when Gorn should be in there and stopping it and working with the government to do so. The same is true with Ebola. There have been 9 outbreaks which were stopped very early without the international health regulation fake requirement. It was just done. But I think, unfortunately, the world is too focused on waiting for a fake to be announced, which should be prevented from having to be announced. On Canada, the difficult data collection, it is a very difficult issue. And I was talking with Bruce Aylward a while back, and he said that they were inhibited in their outbreak tracing and contact tracing by the fact that data was not being shared. Genetic sequences were not being shared. It's a very complicated issue. There are legal issues, ethical issues, political issues, and physical sharing platform issues. There are a whole series of issues, but they can be overcome. And so the world must work toward that. For Larry asking how Gorn could become more effective, I've written down 5 of a few things, few ideas. First is certainly not an increase in staff at WHO. Gorn was run by 5 people during the SARS outbreak. I asked yesterday, Pat Drury, how many people were there when SARS began? 5 people were running the Gorn activity, but they had a whole WHO to pull on, technical people to pull on, and in addition, they immediately had secondments from the UK, from the US, from many countries to help with the outbreak, immediately, the day after the outbreak began. So that's the first formula. The second is a clear definition of what WHO does as part of Gorn. And that should clearly be helping set up logistics platforms, helping to support governments in training and in coordination of the international technical partners who come to do the response. Third, WHO must have a revolving contingency fund. I'm not sure that $100 million will do anything. What's necessary is a fund of $2 or $3 million, which is a revolving fund, which lets WHO get out immediately, because donors will give overnight when there's an Ebola outbreak or any major outbreak as well. We've seen it in the past, we'll see it in the future. And so I just to give an example, when Peggy was at the Nuclear Threats Initiative, she provided to WHO a revolving fund, funding that could be used for rapid response, replenished after the outbreak funding had been mobilized. There needs to be, fourth, a clear chain of command within WHO. Who does what, who sounds the alarm, how is it then implemented in countries? And I think it would be interesting to see what went wrong when Gorn did respond to the outbreak in March, why it didn't continue until the end when it went in. And finally, the last thing I would say is that the risk assessment that's done by Gorn should be more transparent. It should be made available to the world. It should be done possibly by an independent committee. And I know that the present committee was calling for action much earlier than action occurred, and maybe if it had been transparent and in public, it would have been more effective. So those are just some of the ideas that I would have. Just two more things on CRIS. The meningitis vaccine transfer was successful, 40 cents a dose, but no country is yet buying it. They're waiting for Gavi to buy it. And that's a difficulty for the donor community to address and address immediately. And finally, for innovations in R&D, we need to get in place what's necessary to respond. We need protocols that are pre-cleared, ethical review of those protocols that's acceptable in all WHO member countries. We need to also have regulatory agreement within countries that are in the Ebola belt or anywhere else where emerging infections are important. And we need to make sure that all this is in place so that when an outbreak occurs, groups like ISARIC, which has been funded by the Wellcome Trust and which was developed by Gail Carson, who was one of those secundees to WHO during the SARS outbreak and ran the clinicians network, can function properly. Thank you.
Okay, there's still a lot of people requesting, but we have just 5 minutes, so please be very concise. I'm going to give 3 words, just Dr. Gotuzzo, Dr. Casvalli, and David Raymond.
One question, short comment also. One of the problems is when you have this new epidemic, is coming so many groups. Sometimes it's the international labs, sometimes it's the doctors who work like MSF, and sometimes the World Health Organization or other groups. And I agree, it will be very important to have one leader international, but we need to put very strong activity in the local places. That is, the exercise is to try to prove to each government, to try to training people to answer with any outbreak, that any outbreak is exercise to try to improve this kind of coordination. For instance, the Ebola problem, the first 4 months, nobody cared because it's only local. Maybe the people feel, this is a new outbreak from Ebola, it's 200 cases, etc. But then when it's coming international, it's coming to call to everybody. And I strongly recommend it to have this kind of exercise, that the global health institution try to train the local, the PAHO and the World Health Organization need to improve empowerment each government. That is the exercise. I remember when in Peru we have the cholera. The people estimate that we have 300,000 and probably people die 30,000. But then in Peru, the local group is coming strong, and we reduce that expectation 90%. That is, the death is not what 30,000, was 3,000. That is, we can reduce, and we receive a lot of help. But somebody need to be coordination in the country, and that, in my opinion, is absolutely very important from the future. That is, each of these new epidemics coming from developing countries. Usually is in the third world. And for that reason, we need to make that exercise. And my second point is related to the research and development. It's very important to push to the ethical committee board, international view, is to try to reduce the time in regulatory approval, because the other way, any epidemic who finishes in 8 or 12 months, you have no time to make any vaccine, any trial, etc. That is, we need to prepare and recommend it, increase the speed and reduce the speed from approval to start very early some research in this condition.
So I sort of begin with a contradiction, because on one hand, we know what to do. Humanity has been dealing with epidemics as long as there has been history. On the other hand, the experiences that we have had will not help us with the next one. Every single influenza pandemic has been different, and the next one will be very different. I was very struck by Dr. Fiedler's talk, in which he basically began by stating definitions. And I think that this is one area in which we ought to think very carefully. What we're talking about here is a human problem, but then it encounters the fact that humanity has organized itself along geographical areas that follow different rules, right? This is exactly the problem that we have in bringing this. Some countries will be easier to take than others. So one of the thoughts that I have, and perhaps Dr. Fiedler can, is to begin to think differently about governance. To look at this as a human problem, and then whatever governance you come up with will have to be something that can channel power, use power, consume it, not necessarily exercise it. Because since every situation will be different, you must have the flexibility in some case to move in the military to have law and order, in other cases to have some very, very different situation. And you cannot predict beforehand what are we going to be dealing with if H5N1 becomes human transmissible. The past will not help you.
David?
Thank you all for your comments. My concern is that we are stuck with a certain way of learning which depends upon the occurrence of an emergency or a problem, and that the only way that we have to measure health is by looking for the occurrence of disease, and when seeing it not there, we assume health. I'm wondering your thoughts about how we might go about measuring. This is something that Jennifer alluded to and David alluded to as well. How would you go about measuring a healthy governance system without waiting for untoward events? What are the key aspects or features or indicators of proper political will, of proper capacity, of resilience? Does it require a test, a provocation, for example? But it seems to me that we must find something better than we're relying upon now.
Thank you. Well, last remark of everyone about these comments, please. Joanne, do you want to begin?
Sure. Thank you very much, Dr. Gattuso, about your remark. And I'm just going to want to reassure you, we all know, and then I think people know the statistic, that international NGO, when we work in the field, it's always a ratio from 1 to 10. Basically, there's 10 national staff for 1 international staff. And so the bulk of the work is always done by national staff. And then with respect to Ebola, I think the particular thing about it was the fact that there was not the know-how, and then people needed to be trained. But actually, we trained 10 more times, and I think CDC with MSF, we trained 10 more times national staff than international staff in West Africa. So I think it's not the training that is the issue for me, but it's when people are trained is how you maintain these people at a certain level that they're going to be able next time around to use it. And it's the maintenance of the capacity and the competence, I think, is for me a bit the challenge. That's one thing. And when you talk about coordination in the country, I think it's a really interesting experience in West Africa because we got different case scenario. At one places we got the MOH who was in lead. In other places we had basically the defense, the Ministry of Defense taking the lead. In other places it was the donors country that was much more in the lead. So we got the 3 type of scenario, and each of them bring them strength, and then each of them bring, I think, their weaknesses. So I think this should be really reviewed carefully because there's a lot of lesson to be learned. And I think that in terms of, I'm gonna finish on that because we're running out of time. But when you say we know what to do, I think it's a bit I'm an ER physician, and you know what? I'm trained to face disaster. And then basically, I'm the team leader when I got a bad patient in the ER. And you know what? Each time around, I just don't know what's going to come in my ER. But you know what? I just face it. And I think this is the kind of mindset that we need to get to ourselves. Instead of getting into this very prescriptive thing, it's just like, let's be the ER doc, who's going to be prepared to face catastrophe. And we're going to have, I would say, a skill set of competency that's going to do it. Thank you very much.
Thank you. David?
Yeah, I'll just make one more comment, and that's on to David's question on what's needed. I think that, you know, when in 1995, the IHR were unknown by everybody, and even when the Emerging Infections Program was set up at WHO, it was very difficult to get the Director General to engage in a revision of the international health regulations. Once the revision was done, I think everybody breathed a sigh of relief. This is a tool which now can work. But it hasn't worked. It hasn't worked as it should. And I think one of the major deficiencies in it, of course, is how do you get from governments, which many times don't respond the way they should, or non-states, to the people, to the communities, to help them build the resilience they need, because that's where the action needs to be. It needs to be understanding and engagement at the community. So I've come from thinking about how important the IHR were to a belief that informal governance might be best. Informal governance avoids a lot of political difficulties that can occur from formal governance. It permits better engagement of people who are involved in that governance structure, and it also may be more effective. And I base this on the model of the polio eradication initiative, which does have an informal governance, which meets once a week by telephone, which decides how to move ahead, or at least used to do that, and it avoids the political issues that occur when you're sitting on a formalized board. So I've come from 1996 to thinking the IHR were the most important tool for the world internationally, to an understanding that informal might be best.
Thank you. Wow.
That's very interesting. I was the only observation I wanted to add is maybe I'm a little more optimistic than perhaps some on the capacity to learn from experience and to be able to use the cases to adapt in a way, remaining humble that you never prepare exactly for what's coming. But you certainly can prepare better than you otherwise would be. And so as imperfect as it inevitably will be, I think the exercise is worth really working hard on. I think Margaret wants to add one final word. You saw.
Yes, you want to say,
okay.
to have the last word.
Truly, I mean, David, we've been working together formally and informally too. It's really struck me. Actually, both formal governance and informal governance need to come into play. And I have to share with you, the way we managed the outbreak in Senegal, in Nigeria, and also in Mali was using the IHR formal treaty and then pick up the phone and talk to the leaders of the country to impress upon them what are the trade-offs for action or non-action. And it worked in those three countries. And of course, Joanne, you and I have been talking about this is too sensitive to talk about military assets at one point, right? And I said to her, we have to come to this. We don't use the military as in the form of soldiers, but we need to use the military logistic power and assets. So you were talking to some important government who shall remain nameless, you know who they are. And I am also using my informal network to do that. So what am I saying? There are opportunities where you need to use the formal framework, the compliance, because countries sign up to the IHR. They cannot walk away from their promises. So that has to be formal in terms of IHR core capacities. But get rid of this self-declaration. You know, learn from the OIE how some kind of, you know, peer evaluation or independent evaluation or whether or not the countries keep the promise. But then the informal network need to kick in. Now, I also want to tell you one thing about informal governance. It's so important. It's not true that WHO cannot work with the industry. Please get this notion clear. In peacetime, it's more difficult. During crisis, we always work with the industry. And I have to thank the industry for them investing in Ebola R&D for $1 billion and not getting any return. So we need to make that case for those people who don't want WHO to work with the industry, to understand how can we do the governance properly by formal and informal mechanisms. The sharing of information. I'm telling you, my dear sister, when you were talking, I love you. And WHO is actually well placed to be the coordinator. But I want to tell you, nobody wants to give information. And people are so jealous. And so how are we going to overcome that? In the polio, I twist a few arms, and we managed to get all the information we need. And it is just helping countries to understand the value they can bring to global health and not insulting them in public. That is the most important lessons. How can we engage government leaders and not to name, blame, and shame them in public, but behind the scene to tell them if you don't take action, this is going to happen, ABC. So, sorry, I took a long time to share my passions and all the informal things I'm doing. Don't tell my member states, otherwise I'll be sad.
Yes, this is not being recorded. That's too late.
Okay, thank you very much. For me, it has been a pleasure to share this first and second part discussion. I think that you have been very helpful for the work of the Commission, the same with the first exposition that we had in the first part. I'm not doing a synthesize of all the discussion, but what I wanted to emphasize is the need of combined legitimacy and capacity, and to put the people at the center, and the public health is the umbrella that has to lead us, to continue lead us, and not this other umbrellas that could be around there. That's what I learned in this table. So we are going now to the lunch break and resume at.
Let's resume at 1:45.
Okay. Thank you.
Thank you, Jimena, and thank you all for your wonderful presentations.